Today, we are presenting a lecture on the screening and diagnosis of colorectal carcinoma. These are the learning objectives. By the end of the session, the learner should be able to recognize the significance of screenings, know about the epidemiology of colorectal cancer, comprehend the risk stratification for colorectal cancer, understand the Asia-Pacific guidelines for screening of colorectal cancer, and know the management of colorectal cancer. Epidemiology. Colorectal cancer is the most common cancer affecting the Singapore male population. There are around 4,800 cases annually. The average population risk for developing colorectal cancer in Singapore is among the highest in the world. Despite increased knowledge on colorectal cancer and better treatment, colorectal cancer incidence and mortality rates in Asia has continued to rise. Early detection has been shown in clinical trials to improve survival, and consequently, screening for colorectal cancer has been shown to improve survival and is recommended for average-risk individuals. Adenoma-carcinoma sequence. Due to the pathogenesis and natural progression of the disease, most colorectal cancers still arise from adenomatous polyps. They progress from small to large polyps, transform into dysplasia, and finally, adenoma-carcinoma. And this process takes around 10 years and therefore allows for ample screening opportunity. Adenomas are also more common in men than women, and its prevalence increases with age. Polyps are categorized into non-neoplastic and neoplastic. Non-neoplastic polyps consists of hyperplastic, mucosal, inflammatory pseudopolyps, and submucosal, whereas neoplastic polyps includes serrated polyps and adenomatous polyps. Almost all colorectal cancers arise from adenomas. Adenomas are dysplastic and have malignant potential, with nearly 2/3 of all colonic polyps being adenomas. Risk stratification for colorectal carcinoma is divided into average, increased, and high risk, mainly looking at the risk factors for age, male gender, family history, smoking, and obesity. An individual is considered at average risk when he or she is asymptomatic, has no family history of colorectal cancer, or has family history confined to non-first-degree relatives or relatives more than 60 years old. An increased risk individual is defined as someone who has one or more first-degree relative with colorectal cancer, personal history of colorectal neoplasia, prior endometrial, ovarian, or breast cancer, and those who have had pelvic radiation. For a high-risk individual is someone who has hereditary or genetic predisposition for colorectal cancer, family history of familial adenomatous polyposis or FAP, hereditary gastrointestinal polyposis syndromes, hereditary non-polyposis colorectal cancer HNPCC, or patients with long history of extensive inflammatory bowel disease. Screening tests. These are the common screening tests used to screen for colorectal cancer. A stool-based is the immunochemical-based fecal occult blood test or fecal immunochemical test, IFOBT or FIT. This has largely replaced the guaiac-based fecal occult blood test, GFOBT, because it responds to only human globin, requires fewer stool samples, and has higher sensitivity compared to GFOBT. However, it is unable to detect polyps. Endoscopic exams allow for direct visualization of the colon and for biopsies to be performed. However, bowel preparation and sedation is required and complications such as perforation and risks from sedations may arise. There are two different types of endoscopy, a flexible sigmoidoscopy and a colonoscopy. The advantage of colonoscopy also allows for biopsy of large lesions and has the highest sensitivity for localized cancer. It has a miss rate of 2% for adenomas more than or equal to 10 mm, a 13% miss rate for adenomas 5 to 10 mm, and 25% for adenomas less than 5 mm. Radiological examinations include double contrast barium enema, where no sedation is required, and it is a non-invasive, relatively safe way to examine the entire colon. However, it detects only large adenomas and polyps, and may miss up to 15 to 22% of colorectal carcinomas. A colonoscopy must follow any detection of abnormalities. The CT colonography, on the other hand, has sensitivity of up to 96% for colorectal cancer detection. However, the CT colonography is less effective than colonoscopy in detecting advanced lesions and is associated with a twofold longer duration of screening-related symptoms. Thus, it's only recommended when total colonoscopy is not possible. Recommendations for screening for colorectal cancer. Some of the recommendations include a risk-stratified scoring system. For example, the Asia-Pacific Risk Score is recommended to select high-risk patients for early colonoscopy. The FIT, GFOBT, flexible sigmoidoscopy, and colonoscopy are recommended for colorectal cancer screening. For an average-risk individual, screening has been shown to improve survival, and it is recommended to begin screening at age 50 up to 75 years. With a quantitative fecal immunochemical test (FIT) done annually. It should be noted that using FIT as a first-line test for early detection of colorectal carcinoma, the number of colonoscopies required may actually be reduced relative to the GFOBT or colonoscopy screening. Besides detecting colorectal cancer, the FIT has been shown to have almost a twofold increase in the detection of advanced adenomas. The FIT should be done once annually. 2 specimens collected on 2 separate days is recommended for screening of average-risk individuals. Once a FIT is positive, a diagnostic colonoscopy indicated for the examination for the entire colon. CT's colonography is not recommended for colorectal cancer screening. It may be used in cases when total colonoscopy is not possible. If there is a positive finding in colonoscopy, please see the following slide for details. For an increased risk individual, screening by colonoscopy is indicated and should begin at 40 years old or 10 years prior to the youngest case in the family, whichever is earlier, and should be done every 5 years. For a high-risk individual, screening by colonoscopy is also indicated, and the interval of screening shortens to every 1 to 2 years. The age when screening begins differs for diseases. For example, the HNPCC patients should begin screening at age 20 to 25 years old, and the FAP patients begin screening at 10 to 12 years from puberty. Colon polyp surveillance. There are different types of detected polyps and hyperplastic polyps. They can be divided into serrated polyps or lesions, high-risk adenomas, and low-risk adenomas. In terms of histological classification, the glandular architecture of adenomas is characterized as tubular, villous, or tubulovillous adenomas. Low risk includes tubular adenomas. High risk adenoma includes villous histology, increasing polyp size more than 10 mm, multiple, more than or equal to 3, and high-grade dysplasia. These are the risk factors for cancer within an individual adenoma. If an index colonoscopy shows low-risk polyps, colonoscopy surveillance should be considered in 5 to 10 years. Patients found to have high-risk polyps should undergo colonoscopy within 3 years after the initial polypectomy. Patients with more than 10 polyps should undergo repeat endoscopy within 3 years also. Patients with uncertain removal, repeat endoscopy in 2 to 6 months to confirm thorough removal. Screening colonoscopy confers both high sensitivity and specificity and should be performed once every 10 years for patients with no risk factors provided that there is complete cecal intubation, no abnormalities or polyps seen, and complete removal of polyps at the baseline exam, as well as adequate bowel preparation and full bowel visualization. Colorectal cancer, especially in the early stages of disease, can be cured surgically. Surgery is the only curative modality for localized colon cancer and potentially provides the only curative option for patients with limited metastases. Although resection is the only potentially curative treatment for patients who are not surgical candidates, other therapeutic options such as thermal and radiofrequency ablation techniques exist. It is also important to note that although surgery for localized disease is potentially curative, it has been shown that post-operative adjuvant chemotherapy provides significant disease-free survival benefit as it reduces the recurrent rate, particularly within the first 2 years of therapy, and is of some benefit in the next 3 to 4 years. For patients who present with metastatic disease and who are not surgical candidates, chemotherapy, particularly 5-fluorouracil, remains the backbone of chemotherapy for colon cancer, both in the adjuvant and metastatic settings. However, because of the potential side effects and significant toxicity of chemotherapy, the key clinical question is the selection of the most advantageous drug combination and sequence individualized to patients with colorectal cancer. Such decisions are made based on information of the tumor biology, patient overall health performance status, organ functionality, and pharmacogenomics testing. In summary, colorectal cancer carries significant cancer burden for the Singaporean community. However, there are efficient screening methods that exist which will aid in early detection of colorectal cancer and reduce incidence of advanced disease through detection of early-stage adenocarcinomas and the detection and removal of adenomatous polyps. Here are a few key references for further reading.